So I think in St. Gallen now there is consensus that in HER2 positive early breast cancer, we do the neoadjuvant approach unless it's a tumor like 2 centimeters or less node negative, where we can take the patient to primary surgery. And then if that diagnosis is confirmed, continue with the APT regimen of 12 times paclitaxel plus trastuzumab for a year. For other patients, there was broad agreement across the different experts from different nationalities and even continents that neoadjuvant therapy would be the way to go. There was a bit of a discussion on which is the appropriate chemotherapy backbone for the trastuzumab-pertuzumab dual blockade in the neoadjuvant setting. I proposed that we should give less anthracyclines because of the TRAIN-2 data and all the evidence that supports an anthracycline-free regimen like the BCRC06 trial or the Christine trial. But there's colleagues who say that all of these trials really don't confirm for sure that anthracyclines should not be given. And then came patients' concerns, but also expert concerns from countries where they didn't have access to dual HER2 blockade, that maybe if you don't have to the optimal HER2 therapy, you should use an anthracycline taxane backbone. So that was basically it until surgery. And then after surgery, for patients with non-PCR, we would recommend to continue with 1 year of trastuzumab if the tumor has always been node negative, and if it's been node positive, continue the dual blockade based on the affinity data. And for patients with non-PCR, continue with TDM1 for 14 cycles based on the Catherine trial. So it's a pretty uniform schematic of the treatment algorithm. There was a little bit of discussion on the panel then on, I think it was Sunday, with regard to the role of Neratinib. And because we have a registration in Europe for hormone receptor positive high-risk patients, and the expert said, well, the data was done based after trastuzumab adjuvant therapy, so it does not reflect the gains the patient would get from 1 year of Neratinib after the first year of anti-HER2 blockade if the patient had already seen TDM1 and dual blockade. So that is something that one could mention to the patients, but the experts recognize that is not a mandatory step of treatment, but rather an offer we could make to high-risk hormone receptor positive patients.